Hi everyone, welcome to our very first lecture on the Introduction to Anesthesia Pharmacology. In this first part, we're focusing on pharmacokinetics. Before you can really understand anesthesia drugs like propofol, fentanyl, rocuronium, or inhaled anesthetics, you need to understand what happens to those drugs after they enter the body. This is what pharmacokinetics is. This lecture is meant to give you the foundation. I'm not trying to overwhelm you with every advanced detail right now. I want to build the framework first because once you understand the framework, the rest of anesthesia pharmacology becomes much easier to understand. So, pharmacokinetics simply means what the body does to the drug. And this is different from pharmacodynamics, which is what the drug does to the body. These are key phrases to understand. They'll follow you all throughout school. So, in this lecture, we're following the journey of the drug through the body. So, once again, pharmacokinetics, what the body does to the drug, pharmacodynamics, what the drug does to the body. Today, we're focusing mainly on pharmacokinetics. So, why does this matter in anesthesia? In anesthesia, this matters a lot because we're giving powerful medications that work quickly, and small differences in drug behavior can create major differences in patient response. We care how fast a drug works. We care how long it lasts. We care how deeply it affects the patient. And we care how that drug behaves differently in different patients. This is why pharmacology is not just something to memorize, it's something you have to understand. So, introduction to ADME. The main framework for pharmacokinetics is ADME, or ADME. This is the basic journey of the drug through the body. So, ADME, A is for absorption, D is for distribution, M is for metabolism, and E is for excretion. Absorption is how the drug gets into circulation. Distribution is where the drug goes once it is in the bloodstream. Metabolism is how the body chemically changes the drug, and excretion is how the drug leaves the body. If you understand these 4 steps, you understand the basic framework of pharmacokinetics. So, drug enters the body, moves through the body, gets changed, and then leaves the body. So, let's start with absorption. Absorption is how a drug enters systemic circulation. In anesthesia, the route of administration matters a lot because the route changes how fast the drug works, how predictable it is, and how useful it is in a given situation. So, absorption, how the drug enters circulation. We have IV, inhalation, oral, and transdermal routes. Let's start with IV administration. This is one of the most important routes in anesthesia because when a drug is given intravenously, it goes directly into the bloodstream. That means the onset is very fast and the bioavailability is essentially 100%. So IV has immediate onset and 100% bioavailability. This is why IV drugs are so important during induction and in emergency situations. Think about propofol. You push it IV, and within seconds, the patient becomes unconscious. That speed and predictability are exactly why IV administration is so valuable in anesthesia. So, moving on to inhalation administration. This is also central to anesthesia because this is how we deliver volatile anesthetics. With inhalation, the drug enters through the lungs, diffuses across the alveoli, enters the blood, and then travels to the brain. So, lungs, through the alveoli, into the blood, and then into the brain. One of the big advantages of inhalation anesthesia is that it is continuously adjustable. You can increase or decrease the inspired concentration and change anesthetic depth during the case. That makes inhalation anesthesia especially useful for maintenance. So it's easy to titrate and it's good for maintenance. But inhalation depends on things like ventilation, cardiac output, and the blood gas solubility of the agent. So again, route matters because it changes how quickly and how effectively the drug works. Next, let's talk about oral administration. This is much less important for induction or intraoperative anesthesia, but it still matters in perioperative care. Oral drugs must go through the GI tract and then through the liver before reaching full systemic circulation. That is called first pass metabolism. So there's a slower onset and it undergoes first pass metabolism, so you're not getting the full 100% of the drug. So oral drugs are not useful when you need immediate anesthetic effect, but they can be useful for postoperative pain control and preoperative medication management. Lastly, transdermal administration means the drug is absorbed through the skin over time, and this is not useful for induction, and it is not useful when you need rapid control. But it can be used for steady, prolonged drug delivery, such as long-acting pain control, or for antiemetic effects, like with the scopolamine patch behind the ear that we often use for patients with a history of PONV or postoperative nausea and vomiting. So transdermal gives you slow, steady release. The big idea with absorption is this. The route changes the speed, predictability, and clinical usefulness of the drug. So all four of those. Once the drug is in the bloodstream, the next question is, where did it go? That is distribution. So distribution is where the drug goes after entering the blood. Components of this include blood flow, lipid solubility, protein binding, and redistribution. So blood flow. The first thing that affects distribution is blood flow. Highly perfused organs get the drug first. That includes the brain, liver, kidneys, and heart. This is very important in anesthesia because the brain gets a lot of blood flow, so IV anesthetic drugs can reach the brain very quickly. That is one of the major reasons drugs like propofol work so fast. So remember, highly perfused organs get drug first. The next factor is lipid solubility. Many anesthetic drugs are highly lipid soluble, which allows them to cross membranes easily, including the blood-brain barrier. So lipid-soluble drugs cross membranes fast. That matters because for many anesthetics, the target is the central nervous system. So if a drug crosses the brain quickly, the onset will be faster. Another important concept is protein binding. Some of the drug in the bloodstream is bound to plasma proteins, and some of it is free. Only the free drug is pharmacologically active. That's very important. Only the free drug is pharmacologically active. You have bound drug. Free drug is what we care about because that's what creates the effect in the patient. So if a patient has low albumin, they may have more free drug available, and the same dose may hit that patient harder than expected. That is a good example of how patient physiology changes drug behavior. And then we have redistribution, which is a huge anesthesia concept. After the drug initially goes to highly perfused organs like the brain, it can move into less perfused tissues like muscle and fat. So redistribution is drug moves from brain to muscle and fat. This helps explain why some IV anesthetics wear off quickly after a bolus. For example, with propofol, the patient may begin to wake up, not because the entire drug is gone, but because the concentration in the brain has fallen as the drug redistributes into other tissues. So it goes from the brain to the muscle and fat. That is a major concept in anesthesia. Recovery is not always about the whole drug being gone. Sometimes it is about the drug leaving the effect site, like the brain. Next is metabolism. Metabolism is the chemical transformation of the drug, usually into forms that are easier for the body to eliminate. Metabolism, again, chemical transformation of the drug, and it occurs mostly in the liver. So in anesthesia, the liver is the main organ responsible for metabolism for many drugs. You have phase 1 and phase 2 reactions. Phase 1 reactions modify the drug molecule. Phase 2 reactions usually make the drug more water-soluble, so it can be excreted more easily. At this stage, the most important thing is not memorizing every biochemical detail. The important thing is understanding the clinical consequence. So phase 1, modification. Phase 2, conjugation. If metabolism is slowed, drug effects can be prolonged. That means age matters. Liver function matters. Genetics matter. And drug interactions matter. So it's affected by age, liver function, genetics, and drug interactions. For example, an elderly patient or a patient with liver dysfunction may clear certain anesthetic medications more slowly, which can prolong sedation or recovery. And some drugs are unique. For example, remifentanil. It's metabolized by plasma esterases, which help explain why it has such a rapid on and off behavior. So again, remifentanil, plasma esterases. The final phase is excretion. Excretion is how the drug or its metabolites leave the body. So excretion, one more time, is removal of the drug from the body. So kidneys, lungs, and bile or GI are the three main processes involved generally. The kidneys are a major route of excretion for many drugs and metabolites. So if kidney function is impaired, drug clearance may be delayed. The lungs are also extremely important in anesthesia because volatile anesthetics are largely eliminated through exhalation. That means ventilation matters during emergence. If the patient is ventilating well, they can eliminate inhaled anesthetics more effectively. If ventilation is impaired, emergence may be slower. And then some drugs or metabolites may also leave through bile in the GI tract. That is less emphasized in basic anesthesia training, but it is still part of the full picture. So, to bring all of this together, pharmacokinetics is what the body does to the drug, and the framework is ADME, or ADME. Absorption is how the drug gets into circulation. Distribution is where the drug goes. Metabolism is how the body changes the drug. And excretion is how the drug leaves the body. So one more time, ADME, absorption, distribution, metabolism, excretion. In anesthesia, these ideas are not just academic. They explain onset, depth of effect, duration, and recovery. They explain why the same medication can behave differently in different patients. And they explain why anesthesia requires individualized thinking, not just memorized doses. In the next lecture, we're going to cover pharmacodynamics, which is what the drug does to the body. That's where we will talk about receptors, drug classes, dose-response relationships, potency, efficacy, and therapeutic index. Thank you for joining us to build your foundation for pharmacokinetics. And if you have any questions or need clarification on anything or any of these concepts, please leave a comment and send us a message. Thank you.